Good afternoon, and welcome to the ACHE 2 session, Defining and Advancing Health Equity. Thank you for taking all your pictures of the fish and staying in the room and joining us. We appreciate the opportunity to share with you what we think our organizations need to be doing in order to lead the creation and advancement of health equity. I want to thank Russ and the team for the great work that they have been doing, building connections for now, I think it's been 9 years. I have had the opportunity for working with Health Connect South since its beginning, and I'm very proud of the growth that we continue to see. My name is Valerie Montgomery Rice. I am the president and CEO of Morehouse School of Medicine, and I have the opportunity to be joined today on stage by Dr. Adrienne Tindall, who is the executive vice president of health affairs and dean at the School of Medicine, Morehouse School of Medicine, Ms. Gina Bryan King, who's the director at BlackRock, Mr. Del Vecchio, okay, close, Finley, President and CEO of Atrium Health Navicent, and Norman L. Wright, who is Executive Vice President for Health Equity at United Health Group. The diversity of the panel is intentional. Intentional because this is about building connections between organizations that are committed to leading the creation and advancement of health equity through who we educate and train, like at Morehouse School of Medicine, organizations like United Health Group that has a vision for ensuring that they remove the barriers such that people can have healthcare opportunities through access to care to the highest quality of care. Organizations like Atrium Health, who are committed to ensuring that when one comes to a location for health care, that they have the most optimal experience, and organizations like BlackRock, who invest in many of our industries to ensure that we are aligned in our intent and our reasoning for why we believe that health equity should occur. One of the things that I was asked to do was to sort of help define what we mean by health equity. And you all, there are a lot of graphics that speak to what health equity is. But this is one of the most simplest, the simple ones that I've identified. It is about these three little friends who wanted to go to the baseball game. They were late. They all paid their $5. So they did have equal access. They paid their $5. One of them was short, one of them was medium height, one was tall. The tall friend said, "Let me give each of us a box because we are standing behind the fence and we can't see over the fence." Because the purpose was what? To come to the game, to see the game. And he gave everybody the same box. That's equality. That's a great friend who looks out for you. But the short person still couldn't see the game. Medium height person, nose was scraping the edge of the fence. Tall person was actually blocking the other people who were late by that time. But what if the tall friend had said, "Let me give 2 boxes to my short friend and 1 box to my medium height friend, and I won't take a box at all today because I'm already tall enough to see over the fence." That's what equity is. It's about giving people what they need, when they need it, and the amount they need to reach their optimal level of health. And people come with pre-existing conditions. They come with genetic diagnosis. They come with not being employed. They come with living in rural areas. They come with a lot of different things, and our opportunity is to put the right things in those boxes for people to be able to look over the fence. And if we keep it that simple and stop worrying about why they're short, or why they medium height, or why this person is too tall, but meet people where they are based on the circumstances that sometimes they are inherited and sometimes they made some bad choices. Create some grace around this, we can achieve health equity. Now, the third part of this is the reality we live in, okay? But we can move beyond that, guys. And that's what the purpose of Health Connect South is, for us to put together our resources to make sure that we're focused on the middle and not at the end. So thank you for joining us today. And I am going to sit as I moderate this because there are so many wonderful questions that we have. It is meant to be a dialogue. And I was the only one who was allowed to bring a slide, so they do not have any slides. Let me start with, please, the opportunity for everyone to introduce themselves, and as they do so, to also answer the first question. And the first question is, what methods in your organization is your organization using to strengthen care delivery to vulnerable populations? And I'll start with you, Delvecchio. Okay, pronounce it right so I don't mess it up.
Delvecchio.
Delvecchio.
Thank you so much, Dr. Montgomery.
And he's from Atlanta. He's not from Paris. He's from Atlanta.
I am a proud Grady baby from the south side of Atlanta. Yes, thank you so much. It is such a privilege and an honor to be with all of you, particularly you, Dr. Montgomery Rice, and my co-panelists, and really just appreciate Russ and Health Connect South for the opportunity to be here. As stated, my name is Delvecchio Finley. I have the privilege of serving as the president and CEO of Atrium Health Navicent. Atrium Health Navicent is the central and South Georgia market of Atrium Health, based out of Charlotte, North Carolina. So we represent a market that covers a substantial part of Georgia, stemming from Macon down through the southern part of our state border. When we talk about the things that we do in our organization to advance health equity or strengthening the care to vulnerable populations, we start with the mission. And at Atrium Health, our mission is to improve health, to elevate hope, and to advance healing for all. And the for all part is an intentional part of our mission. We have a cultural commitment that says that we create a space where all belong. And in so doing, we take a very data-driven and thoughtful process to look at a solutions-based orientation to providing care to vulnerable populations. Meaning we don't start off with a solution looking for a problem, but we start off with a careful identification of the core problem, the root causes of those problems, and then we endeavor to identify some of the solutions that will get at helping us to advance that mission. How are we going to improve the health? How are we going to advance healing for all of our community? We use a lot of data, both internal and external data. We use a lot of qualitative information from a lot of partners that we work with, because we believe that our organization is not just a healthcare organization, but if we're going to be an organization that's geared to advancing health, as I said before, that health extends way beyond the borders and the boundaries of our doors, of our hospitals, our clinics, our urgent care settings, and the like. We do a lot of things that are obviously geared at addressing those disparities. So when we take an analytical approach to identify, say, disparities in readmissions for heart failure patients, or the incidence of hospitalizations or ED visits for diabetics, we try to do geospatial orientations to say, here's a community where there are some access challenges or there are some care gaps. And then we design solutions or apply solutions that we know have worked in other settings, because we are all about the case method as well, copy and steal everything, right? If it it has worked, we don't necessarily have to be the arbiter, although we are a very innovative organization. Innovation comes in many forms. And so we have done a bunch of programs to advance the health of our community specific to health parameters. But beyond that, it's also about going upstream and identifying other things that impact health. So some of the things we call the social determinants of health. So we've done things like creating school-based health initiatives that are virtual care programs designed to keep kids in school. In our rural communities, a lot of care gaps occur when parents have to lose their jobs or leave their jobs and experience vulnerabilities that way in terms of getting their kids access to care. So we endeavor to bring the care to them. We've also, and I'll end on this one because I could go on forever, we've also endeavored to do things around addressing food insecurity. So one of the recent things we've done in our Middle Georgia market in partnership with our food bank is to create what we call our food pharmacy with an F. And that's about understanding food and nutrition as a core part of advancing and sustaining health. And in our food pharmacy, it's not just a food pantry. We also provide nutrition counseling specific to a patient's disease state or illness state that's designed to help them to be very thoughtful about taking care of their nutritional needs, but also being very sanguine about the fact that their ability to do that really is predicated on having the resources to do it, and we feel that we're an integral part of that. So there's a lot of different other things that we do with our Healthy Communities teams and others, but those are some of the things that we do to address care in vulnerable communities.
So thank you for that. So you've given us a vision of what happens when someone has access to health care, and that matters. So now I'm going to go to Norman, who's going to talk to us and answering that question, what methods are your organization using to strengthen care delivery to vulnerable population? Because you have, I know, a different part of how we're trying to build that bridge between health care and health.
Yeah, thank you, Dr. Montgomery Rice, and it's wonderful to be here. I think this is the first time I'm on a stage in over 2 years. Mm-hmm. And probably we're doing it sort of multiple times per month. So wonderful to be with you all, wonderful to be in the hallways, having really good and meaningful conversations around what we're doing to positively impact the healthcare system and modernize it. And this particular topic is very near and dear to, I know, all of us, and it's a real passion for me. I am the Executive Vice President for Health Equity Strategy at our enterprise. I also have the privilege of chairing our United Health Foundation. I mention that because our philanthropic agenda is a big part of how we get after disparities and health equity across communities outside of the populations we directly manage. I like to give examples when I'm talking about what we're doing, so I think I'll go to just a couple. Del Vecchio hit a number of themes that were very similar in terms of what we're doing, so that was good to hear. But let me give you just two examples, and let me also start with the mission. Our mission is to help people live healthier lives and to help the health system work better for everyone, big E, everyone. And we can't really get to that mission if we have parts of our population that aren't receiving full and equitable care. So I don't go to bed on any evening, any night, feeling really great about how we're actualizing against our mission until I see numbers and evidence showing that we're really making demonstrated progress against some of these key disparities. And it's great to hear Dr. Ford talk about maternal. It's number one on our list. Certainly, we really need to get after these disparities. So with that, just two quick examples. We all know that lots of vulnerable parts of the population struggle with getting access. They struggle with social determinants, as Del Vecchio mentioned. We have a program we call My Connections. And essentially what it is starting with a developed data model. We go out and we look at our populations and we try to understand on a member and patient level where people may have some risk of being impacted by a social determinant. And it's been amazing. We've done over 4.1 million of those screenings last year. This year so far already over 3.2. And essentially it's identified that there may be an issue and then develop engagements and interventions that get directly at what that housing issue, that financial issue, that transport issue, that security and safety, food, nutrition, et cetera, whatever that may be. So We then arm our nurse practitioners, folks in all of our clinics, the folks on all of our phones, and then what we're doing from a digital perspective with flags and alerts that says, hey, this member patient you're talking to likely has a social determinant issue. Make sure you engage and make sure you then do care coordination to get them the right kind of support that they may need. That's been a huge success for us so far. We're looking to get to more and go deeper in our populations, but that's one example that I think we're super proud of. Another, tell this story very quickly, of all of our seniors out there who are often incredibly vulnerable, living on fixed incomes, and many cases can't get access to the care that they need. We have a program called House Calls. And we send our nurses into homes once per year, annual wellness visit, but that visit is more than just a clinical medical look. It's a behavioral look. It's a spatial look at their surroundings, looking for fall-related and other injury risks. And it's also, again, looking for social determinants as to where we may need to help them get access to services. Did over 2 million of those last year. We're going to top that number this year. And as a result, we're seeing 14% fewer ER admissions across that population. And we're seeing, I think, 6 or 7% higher physician visits, which means when that nurse leaves them and they know they have to follow through on their care pathway plan, they're doing that. So just two examples of where we're reaching out and reaching into communities to make sure that we're providing care for the folks that don't have the traditional access levels.
Thank you, Norman. So I'm hearing a theme evolving that's driven around data, access to technology, and also meeting people where they are. So sometimes we have to go into the homes of individuals and see people how they actually live in their spaces.
Yes.
And then be able to accommodate them once they get to the healthcare facility to what happens beyond that. So Jenna, what methods would a BlackRock, what has BlackRock been doing to strengthen care delivery to vulnerable populations?
Thank you, Dr. Montgomery Rice. Really appreciate being here. And just a little background on myself before I can kind of dive into that question. I'm Jenna Ryan Krug. I'm a director at BlackRock. For those who don't know BlackRock, we are the world's largest asset manager. We're offices globally. Where I sit is one of the hats I wear is a credit research analyst within our municipal team. For those who don't know, municipal debt is kind of the backbone of the U.S. from an infrastructure standpoint. Tax-exempt debt from federal and state income taxes to finances, not just roads and bridges, but schools, city halls, hospitals, really kind of water and sewer systems, mass transit, kind of you name it. Kind of you can't go throughout your day without touching some type of municipal issued debt. I've also been involved from the DEI perspective across the investment platforms, representing our business, as well as for the past 5 years taking a bigger role in ESG integration within our asset class, more of the focus on kind of the S in ESG, given that municipal bonds do have a public benefit in order to be issued. So kind of reframing how that question is how we're looking to strengthen delivery to vulnerable populations. I think I'm going to look at it from how we are from our corporate DEI perspective. So we have 3 pillars of our diversity, equity, inclusion strategy. So talent and culture, our role as a fiduciary, and social impact. And so social impact is where I think we can somewhat move the needle, both at the high-level corporate area and then the grassroots local level. So our social impact strategy really is to invest in the long term for sustainability of underserved communities. And how we do that, so looking at the top level, in early 2020, BlackRock made a charitable donation, about $589 million, to establish the BlackRock Foundation, which is really looking at how do we provide long-term philanthropic solutions for these communities. It enables us to partner with over 75 organizations, serving hundreds of thousands of individuals across a broad spectrum of philanthropic interests. In 2020, we also devoted $50 million in COVID-19 relief. One of the things that BlackRock has done more is really kind of driving it more employee involvement. So part of this is that they gave all of the 15,000 plus employees a $50 philanthropic credit to donate to their nonprofit of choice across the slate. We worked with an organization called Fast Forward to look at their Tech Accelerator program, and two of the companies that were on that as it related to health equity are IntelliHealth, which is an open source mobile telemedicine for that last mile of healthcare delivery, and then Hopebound, which looks at it's a virtual therapy platform for low-income youth at high risk for teen suicide. So those are two ways from that corporate level and driving in that employee engagement that we're trying to look at some of those healthcare determinants. I think what I find more impactful is kind of that employee grassroots efforts, and this is manifested in several ways. We have several employee networks. One of them is our Gives Network, which is a grant program where employees can nominate certain nonprofits in the community to receive grants of $1,000 up to several thousand. As part of this, there's also volunteer opportunities as a way to get employees to volunteer with these organizations, and then for each hour you volunteer, you also get a $25 credit per hour that's donated. So different ways to get involved there. But I think it really does empower you, because BlackRock is really focused on helping the communities in which which they have offices and where their employees live, understanding that the needs of the communities are different. So if we talk about health equity, or we talk about education, or we talk about affordable housing, they may be similar at the top, but when you look at the communities, they manifest themselves in very different ways. One thing that we've really been focused on across fixed income is food insecurity, given that we tend to have a lot of food drives during the summer months, so that we're really stocking those pantries when they're at their lowest and they're most in need. A lot of holiday donations, whether it's putting together Thanksgiving baskets or making sure we're donating our time on Thanksgiving to serve meals at soup kitchens, just so that you kind of see what your impact is. And the one thing that I think has been the most impactful for me is about 2 weeks ago, there's an organization we've been involved with for 5 years, America's Grow Row. It's a farm in northern New Jersey that has a purpose of really supplying fresh fruits and veggies to food banks. And I think to bring it back to the topic here we are today, is that they have plenty of stories about how they go to their local food banks, and it was originally just in New Jersey, but they kind of now do kind of the eastern seaboard and as far west as Texas, is that they have people who come up to them saying that they can't afford their diabetes medicine, so they rely on these fruits and veggies on a weekly basis to help them regulate their blood sugar. So I think it's just a powerful message that we have, that we can kind of not only give to them with money that BlackRock enables us through grants or matching donations, but also you can volunteer, and then you really can move that needle. And I think, again, we hear about inflation, but food inflation is real. If you look at numbers from August, dairy is up 16% year over year, eggs are up 40%, flour is up 23%, and this is not going away. We're going to need at least 2 years of normalization from the crop production in North and South America for this to go away, and that doesn't take into consideration drought conditions or the conflict overseas. So I can go on and on here, but I think I can leave it at that.
Yeah, all of y'all are passionate about what you do at your companies, and this is important. But again, what I'm hearing though is community, community, community. So when we talk about building this bridge between healthcare and health, we understand that we can't do it alone, that connections are important, that the organizations that have an expectation that the persons who work with them and for them ought to be contributors to solutions. That's what I'm hearing. And so lastly, Dr. Tyndall, will you share what we do at Morehouse School of Medicine to potentially strengthen care delivery to vulnerable populations?
Thank you, Dr. Montgomery.
And I know
Rice.
you could go on and on about it too, I know.
Well, I was going to say that I am equally as passionate about it as you might imagine, and I have to comment on one of Norman's examples. I give a talk that has a Time magazine cover article on it, somewhere in the 1950s. I just remember there's a Marilyn Monroe's actually in the front, but the most important part of it is one of the subtitle areas is that states, "Where did home visits go?" This is in the 1950s. So we're coming full circle, as you might understand, as we realize really what's impactful. So as you heard, I'm Adrian Tyndall. I am the Executive Vice President and Dean at Morehouse School of Medicine. I'm about a year new, and I clearly have to thank Dr. Montgomery Rice for painting the vision that pulled me across the Florida-Georgia line to Morehouse, and it's been, I think, just absolutely fantastic. And speaking of the vision that was painted, you know, Morehouse, as you know, the vision is about leading the creation and advancement of health equity. And when I think about that, I think about, the inception of Morehouse School of Medicine in 1975 and the fact that this was the intent. Where we come into play is building human capital. None of this could ever be possible without the human capital that has to be built. And as a school of medicine, which is a bit of a misnomer, I'll tell you why in a moment, we're in the business of building scientists and physicians and providers who are culturally competent and really understand the framework, which I think is important to consider. That as I look back at what Morehouse School of Medicine was really conceived to do, it's really about thinking beyond Flexner. We're looking for students who are not just in the business of healing people, but also healing communities. And it really takes, I think, an individual who has a level of commitment that is different, and the institution has to reflect that commitment in order to build that workforce. And I will say, looking back at the history, that what Morehouse School of Medicine has done for the state of Georgia in terms of increasing the diversity of the workforce is just amazing when we think about the physician-provider to population ratios. I think what we have done, though, is we've developed a curriculum and we have provided a blueprint for how we can actually be successful in diversifying the workforce. And it starts with the young student. It starts with young minds. It starts with our pathway and pipeline programs that we establish to ensure that we can track young minds and young students into the healthcare space. We have connected with the AAMC, the Association of American Medical Colleges, that has a focus on this, and we're creating the blueprint for what those pipeline programs can be and how they can actually impact institutions such as ours. But what I will say, though, is that in the middle is the secret sauce of what we do in cultural competency and the kinds of physicians and providers that come out of Morehouse School of Medicine who are dedicated to serving communities, not just healing. And this is obviously represented in primary care. But I would say that the Morehouse School of Medicine is not number one in social mission for naught. We were built for that purpose, and I think that's what we're executing. But I'll tell you what is, I think, even more exciting today. And I would say Dr. Montgomery Rice, a couple rows down here, really created an opportunity to expand what we do, not just in the state of Georgia, but outside of the state of Georgia. We have created a collaboration with Common Spirit Health to build other campuses in other states across the country, to take the model that we have here at Morehouse School of Medicine, to inspire young minds to enter into medical education, to come to our school, to go through our education missions, and go back to those communities to serve those communities. This is what we're doing today. It's one of the things that really excited me about coming to Morehouse School of Medicine because of the impact that is being made and how these collaborations and opportunities, I think, are really changing the landscape of the diversity of the workforce. And that matters. Human capital matters in all of this. Culturally competent care matters in this. The kinds of researchers that we have who focus on issues and problems that might otherwise may not be focused on really matters. And so this is what we were about, and one of the reasons why it was so easy to cross the Florida-Georgia border.
Well, thank you for making that trip, and we appreciate it. It's made my life a lot easier. Thank you very much. But let's stay on this workforce theme, Vecchio, if we can. So everybody doesn't have the fortune of going to Morehouse School of Medicine, and so you have a very diverse workforce, not just by race, ethnicity, and gender, but by what they do in the healthcare system. How do you equip them with the skills, the insight, the self-awareness to deliver on what we are all describing as this culturally competent care? And how does that transcend to the highest quality of care?
It's a fantastic question. I'll try to be very brief. I want to hear from my colleagues because I really am learning a lot here. We've evolved a little bit. I hope there's not a lot of dispute here, but we've moved from what we call cultural competency to cultural humility. Because in many respects, people saw cultural competency as checking a box. We all are doing, I hope, various forms of training and awareness for the various backgrounds that people bring into our settings, and being sensitive to those backgrounds as a means of bringing them into the care experience. It's not about doing to somebody, but with someone, but also understanding that as a means of supporting their ability to continue to care or improve their health as they leave your settings. But the humility aspect of it is you're always learning. And the moment you think you know everything about fill in the blank group is a moment that you stop being culturally competent or humble, and you really do need to exercise what we call appreciative inquiry. If you are coming to people and asking, describing what it is that you are thinking and verifying or validating that you've gotten it right, then you honor someone's humanity in a way that then increases the likelihood that whatever intervention or partnership you're trying to create with them will be successful. So we try to teach and deploy a set of tools and trainings to our teammates all the time. We actually, quite honestly, and I think it's important to say this too, try to learn from our mistakes as much as we learn from just kind of core knowledge, because let's face it, we all make mistakes. It's a part of growth. But at the same time, we continue to say that we need to keep learning and keep growing, and if we approach life and care experiences from that vantage point, we'll be better off for it.
So Norm, I'm gonna pivot to you, because speaking about cultural humility and what we all had to learn head on during the pandemic, right? Obviously, we're not in a pandemic anymore because like only one person wearing their mask, and mine is on my arm. So, but we are in an endemic, and we had to become way more humble. Organizations had to become way more humble. So what changed? What was identified as a need to change within your organization in terms of care access, or how you approached engaging your constituents after this pandemic or during this pandemic?
So I love this question. When the pandemic hit, I had been at the company for about 7.5 years, I guess, at that time. And, we're large and diversified and got reach in many places, and I think generally we do pretty good work. But pandemic hits. I think we all were in a similar place. 4 or 5 weeks in, the data started flowing back, showing the incredibly disproportionate impact on communities of color, Black folks, Hispanics, Native Americans, the rate of positivity off the charts. And in traditional times in our company, it probably would have been run a set of analyses, put together some designs, business case presentation, figure out what investment's going to be required, what expense you need, what capital you need, get the right people convened, boom, 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 and then sometime shortly down the road, you've got a solution you can take into market. And we didn't have that kind of time, right? None of us did. So we were in market with a pretty shell sort of structured solution in about 3 or 4 weeks. And talk about needing to be humble. We walk into these communities, can't show up with a United Health Group van, when, especially as something as sensitive as what's really going on here with this pandemic thing, and especially as we advance to the vaccination phase. I'm not sure I trust you guys, know you guys, et cetera. So the level of sort of listening, really dialing in and engaging, and getting with what I call the elders in those communities, right? The women and men who are running the churches, barbershops, salons, community centers, you name it, and just being on the ground consistently for days and weeks, plugging in and understanding what they're hearing from their folks around them and what it's going to take for us to win their trust and reach them. So we ran this program, we called it Stop COVID. Our analytics told us that you got to run to Chester, just south of Philly, Orleans Parish, and LA. 3 areas that not only were having deep infection rates, but where we actually had some resource and ability to engage. And it was incredible to see so many of our people who had been sort of doing the business in a certain way wake up to a new way of listening and engaging and understanding the community at a pretty deep level. So it was, and Dr. Montgomery Rice, so just one more thing that was a real wake-up call for us that we can't lose. The level of agility, the ability to say, we were talking a little bit about this earlier, you got to get to 80% of the answer and then be ready to run forward with your design and what you're going to do in terms of interventions. We operated at a pace that I certainly had never seen before, and we got to make sure we keep it like that as we're trying to support these communities.
All right. So, Jenna, one of the things that we saw was significant gaps in care. We saw gaps in access to technology. We saw gaps in education attainment, food insecurity, mental health. How did that impact, say, an investment company about how you think about how you deploy your investments or an investment perspective or philosophy?
Great question, and I think, so for the past year, for the past couple of years, I've been working on ESG and kind of given our public market. The past year, I've really been working on developing an impact framework. So impact investing, socially responsible investing, this is definitely something that's been around for a while. It's something that at BlackRock we were trying to be mindful about, given kind of the broader market is still kind of coalescing on kind of what some of these definitions are, and not wanting to kind of have some of that greenwash or that social washing from an investment perspective. And so what we did a lot of time was to dive into kind of the sectors that we think have kind of a lot of these impacts on these communities, be it hospitals, be it school districts, universities, community colleges, mass transit, and kind of what are those gaps? What are those needs for investment? And then tying into kind of looking at data. The US market, it's 50 different states, 50 different ways to issue debt, 50 different regulatory environments, 50 different ways of looking at data. So a lot of big data to look at communities, look at kind of what those gaps are and kind of where can you invest, how can you invest, and how can you really help try to make an impact and close the gap. So as you mentioned, kind of the world came to a halt, and there was this shift online, and I think you can see that technology was a huge impact. Digital connectivity and the information infrastructure really is recognized and is an important catalyst for bridging those economic gaps. And so school went online. Telemedicine became there. But if you don't have access to a computer, you don't have access to broadband, it's very difficult for you to do this. Also, especially on the education front, if you're a single parent or a dual working household, and you still have to go to your job because you are a critical part of kind of the your organization. Mm-hmm. What do your kids do? So it's, a lot of questions arose, and I think what we've been trying to do is use that data to find those areas that we believe are undercapitalized, and I'll talk about that in a minute, to really kind of, for our impact fund, which we launched earlier this year, to really devote capital, invest in that. So we're investing in projects and we're investing in infrastructure because we want to make sure that the infrastructure is there for these communities that might often get overlooked. And I'll say it's a little at odds from a fundamental standpoint when you look at kind of financing a school district, but it has a high poverty rate. It doesn't have a high tax collection rate. There's only so much that local area can absorb from a taxation perspective, that they are lower on the credit spectrum, which means they have higher interest rates. So how can we make sure that they're not necessarily being penalized just because of the makeup of the community in there? And it's kind of a perpetual cycle of them constantly being there if they have those high interest costs, and then they have those high fixed cost burden, and they can never get out under it. So one thing we've done on the data front is we developed a social opportunity model. This is a model that has 37 inputs across various categories. It's usually from governmental data sources, and it's at the county level, so across the 3,000 plus counties in the US. And what we do is we take this data to quantitatively score, screen, and identify undercapitalized areas through an equally weighted county level scoring model. It's community, employment, housing, justice, mental and physical health, and racial equity. It really is giving us a different lens to look at these communities than your traditional financial credit metrics. I will say that half of these are related to health. So in an equally weighted model, kind of health does play a outside proportion in our model. And I don't think it's surprising that the Southeast is an area of vast need, kind of when you take these health factors into consideration. And so what we're trying to do is with this model, highlight those areas with this high social opportunity, and then kind of, as we look at the bonds coming to market, invest in them. Is it a hospital that's putting up new patient towers? What we've seen on the hospital side is there's a lot of new behavioral health units being put in. So diving into kind of what the community is, what the needs are, and how kind of this new center can help try to alleviate some of those areas of concern. Same on the education side. What we saw in LA, for example, it's a second largest school district with 500,000 students. At one point, they were the largest food bank in the nation, delivering more than 1 million meals a day to the students. They also had to hire buses to put Wi-Fi out into the community so that kids could be on there, in addition to applying laptops. They also had to open schools, not so that they could instruct them, but that because parents needed to go to work to pay the bills, and their kids needed a place to safely be during the day to do their lessons. So I think what we've tried to done with our impact framework is, like I said, use data to identify the areas that we think really could use this, that we believe have been overlooked, and really do kind of try to help solve or to help try to close some of these gaps, at least on the infrastructure side.
Thank you, thank you. And Dr. Tyndall, talk to us about, we learned so much in the medical research space post-COVID, but how did it change our focus, not just at Morehouse School of Medicine, but nationally, in how we address health disparities or try to achieve health equity?
You know, that's an incredibly important question. I say this from a couple of different perspectives. One is that, you know, the pandemic really presented an extraordinary opportunity in terms of probably the most decisive acceleration in biotechnology development that we have seen in our lifetimes. And the pandemic itself also uncovered something very significant, that there were substantial inequities across the country in so many ways. The one thing that I will say, I mean, there are several things that stood out. One is that what it really demonstrated and what the pandemic demonstrated, especially when we think about the research and the development of vaccines, is this issue of trust in our populations. I spend time in the barbershops, I spend time talking to individual citizens and groups about the vaccine. And I, as an African-American male physician, had a tough time convincing people about the need. So and why does this matter? It matters because I think it revealed to us one of the huge problems we have in biomedical and clinical research, which is we simply do not have enough of a diversity in our populations. And frankly speaking, the clinical research studies that are out there do not target necessarily the areas that they need to target. Now, I'll give you an example. If you just look at the 2020 FDA snapshot in cancer trials, right? And we know that a minority of the population involved in cancer trials were African Americans, about 5% or less. We know, for instance, that in oncology and prostate cancer, 1.5 times in African Americans compared to the rest of the population, twice times the death rate. And yet, only about 1% of the clinical trials really addressed that specific issue. So it's uncovered, I think, a substantial problem with inequities in our clinical trials. It has uncovered, I think, substantial issues of trust, which oftentimes also means that the researchers and the scientists who are also involved in that work, that workforce also needs to be diversified. That workforce needs to see diversity in order for us to be able to move the needle. So it is really in two spaces that really becomes important, but the pandemic itself, I think, really uncovered some really basal issues that we have to focus on, and I think that the real issue that we have to think about is trust. And I am a fan of mixed methods approach. I think that it's important to really quantify what we see, but trust is not that quantifiable. And we have to go after it in order to really make a difference.
Thank you, thank you. Now, I want to make sure I check my time here. Is that time correct? I have continued time. Okay, good, good. Right? 2:40, right? Great. So I know Russ probably is going to have a fit, but we need to energize you all a little bit. And so want to make sure that we don't lose the opportunity of understanding the talent that we have here. And so I'm going to ask Krishima, my chief of staff, to help us with this, because I want to hear from you all. There's a reason that you joined to come and listen to these experts here, and so we do want to hear from you. So you can start coming if you have a question, and so don't make me not look good, and because I said we were going to do questions, so somebody ought to be getting up to ask a question, because you have people here who are from multiple sectors, who are concerned about health equity, and they have solutions within their organization, and we want to hear your ideas or some of your thoughts that you may want to share to make us think more about the connections that need to be had. This gentleman right here, introduce yourself.
Hi, my name is Avas Bajwa. I'm a co-founder of a startup company. We use artificial intelligence for retinal disease diagnostics. We are working in blindness prevention programs, and I have my co-founder, Dr. Neelam, sitting here. So we just came here to socialize with the community, and what a wonderful discussion and topics so far since morning. And I loved all discussions and introductions from different people. I just want to highlight one of, since there is a topic also on the innovation, bringing new innovations to healthcare. So I have a little different topic, but I'll still pose a question to you guys. So there is globally, as of today, it's a war for global innovations across different regions of the world, including US, China, you name it. Now, the companies I representing a community of startup companies, we have a lot of ideas, we have a lot of innovative ideas, we have technology innovations with us, we have research groups. One of the barriers that we have to cross is the global, and Jenna understands very well, BlackRock is all about data company. So you have a lot of data innovation because of the data and data-oriented companies. So one of the barriers that we are facing is access to data, where we can democratize some of the community level innovations. Like we provide blindness prevention program outside of US as a charity right now, because we are just undergoing the FDA clearance and stuff, but we are very passionate to bring more innovations, but all startups like us are having a barrier where we are far away from the community health because of the access to the data and the network. So that's just my quick question.
So is your question, how do you get access to data such that you can bring solutions for whatever your company is bringing? As a startup company, it's not as easy for you to get access to data. So first of all, thank you for being here, because one of the opportunities of this conference is to build connections just for that. And so let Norm start, and then others who want to chime in.
So love the question, and thanks so much for being here. Two quick thoughts. Have you seen America's Health Rankings? Have you seen that report, by chance? Okay, try to find me later, or if you don't, go and Google it. It's produced by our foundation. It's a very, very detailed report that comes out annually on every community in the country and how they're doing against health conditions. And for the first time this last year, we did a disparities report, which I would love for you to see. I think it's going to give you some insights. The second thing is, and we work with startups and innovative groups all the time, hear that same exact concern. If you develop a relationship with a company like ours or anyone else's, and you can at least get to that step where you can get an NDA in place, you will get access to, it's probably going to be 1 or 2 steps cleansed, but a good enough data set that I'm pretty comfortable you'd be able to sort of think through your solutions, run all the sort of analysis and tests you need to do to come up and validate what you're focused on. So that relationship piece and getting close enough to get access is important.
Adrian, you want to comment?
Yeah, I would say that, and I appreciate that certainly. It is about the relationships, it's about the partnerships. It is, as I said, is also about trust. And it's also about a responsibility with regards to the data and a responsibility to patients from which you are gathering that data. And so it is really, I think that in academia, I mean, we've been debating this for a very long time, and I know where the needle is moving, but we have to be current in terms of taking advantage of these strategies and these opportunities. But we also have to build the infrastructure and the guardrails to ensure that we carry this out responsibly. So I think there's definitely opportunity, but I think and it's not a but, it's an and. We need to also be cognizant of the responsibility we have with regards to patient and patient data. But we have to innovate, which means we probably have to break some of the old habits that we've had in the past when I think about our academic infrastructure and how we actually approach research today.
You want to comment on that?
I actually love everything Dr. Tyndall, actually both Dr. Tyndall and Norman said. I would just maybe underscore one other point. I mean, I spent the bulk of my career serving underserved communities and organizations that serve them, and so this question about access to data, I view from that lens of equity, quite honestly. And I think there's a whole other realm of like who owns the data and how do you deal with the dimensions of, who should, I hate to say it this way, but one, have the authority to grant access to data, but also who determines how that, whatever fruits come from that innovation get dispersed in a way that recognizes the contributions of everybody who are there. So I say it's a really huge obligation of organizations that serve underserved communities to ensure that when you're getting involved in partnerships or collaborations, tech transfer, any of that other sorts of things that result in innovations that get monetized, that benefit actually comes back to the community, not just in the form of, hey, they were able to participate in trials and maybe a handful of them got some kind of intervention that helped them, which is not insignificant. I want to underscore that. But if there is some other entity or communities that get that and then some, I think there's a responsibility and an obligation on the part of the organization and the partnership or the partners to understand that in such a way that we do just what Jenna was talking about earlier, reinvest in those communities so we break cycles where they're not seen as a source of information or a conduit for or a lab for these types of things, but also a place to invest in such a way that they feel validated and that they feel like they can contribute and participate in society as equally as everyone else.
So one of the things we have at Morehouse School of Medicine is something called TX. And the X is for the exponential impact that discovery has when an intervention goes into a community and you can measure the impact of it. And so we all know T0, T1, T2, we're all translating across the spectrum. But it really is all about how do you get to that X factor. Whether or not that intervention that you brought to the community, whether it actually did what it was supposed to do. And the only people who can tell you that is the community. So when we go to these communities and we all go with the good intent. And we should presume good intent until people show us otherwise. But so many times we've shown the community otherwise. And so we haven't built the trust. And so when we are allowed to go into these communities, we have to make sure that we give that information back to them so that they can see their return on investments. And, there are lots of mandates that are going on right now from the legislature and from Congress, et cetera, that is requiring diversity in clinical trials. And all that's well and good, and it needs to occur. And we still will have to make sure that we transfer that information back to the community so that they see the return. You have someone else? Right here, over here.
She's going to stand. Give her a second. Hi, good afternoon. I'm Erin King Mullins. I'm actually a colorectal surgeon here in the area, and I'm so excited to be here today because I feel like more and more physicians, practicing clinical physicians, need to be in rooms like this to understand what's happening across healthcare in general.
We're recruiting at Morehouse School of Medicine. She just-
So my question to the panel, and thanks so much for all your feedback and insights today. How do we equip and empower and inform physicians who are on the front lines, who may not be involved at the larger administrative or industry level, about the opportunities and resources that are out there with regard to some of the initiatives that are in play? And I ask that specifically because me as a surgical subspecialist, a lot of the patients that I see don't have primary care physicians. They don't have long-lasting relationships. They may not know what's all available to them through their insurance plans. And they ask me tons of questions that I, number one, obviously, to some degree can't answer, and I try to help point them in the right direction. But when we also talk about trust, that patient-provider relationship is paramount in, if I tell something to my patient, it's a little bit different than their insurance company, saying something to a patient. So how do we bridge that gap so that we equip the patients with that information directly from their physician, their trusted provider, who they are literally, putting their life in the hands of?
So first of all, thank you for being here, because I know as a colorectal surgeon, you are extreme. You gave a card, great. I know you are extremely busy, but it does matter to be sitting around the table in this diverse space to hear and learn these things and share them with your colleagues. Devika, you want to?
I agree,
take that
and I want to
first?
start really quickly and say I want to give you a card as well, so don't leave with just the Morehouse card. But no, it's a two-way street, I would say, and I really want to underscore this. Healthcare delivery is a team sport, and I think it's sacrosanct, the patient-provider relationship, and I think that I am encouraged by and really appreciate physicians who engage in such a way to say, I want to be a resource to my patient beyond the care that I actually provide to them. But I want to underscore that this is such a complex endeavor and undertaking. It takes a team of people. Your ability to be as continually proficient at your craft of colorectal surgery, I'm sure, I'm going to guess, allows you the time to actually understand sort of current state, what's happening, and how to be a benefit for your patients. The moment you go do another surgery, that's changing, unfortunately, and it's just the nature of this crazy endeavor we have called healthcare here. So it does require a team of people, and I'm sure maybe you have them in your office or a part of your organization. We have them as a part of Atrium, that's my commercial, where we try to complement you in such a way that trust extends from you to the rest of the team in such a way that whether it's a case manager or an admin or a revenue cycle person or a billing person who is working with that patient, who actually helps to navigate these complexities in such a way that it helps them to get the care they need and understand the information they need at the time that they need it, because all those things are just multivariable. So I would say absolutely possible for you to do it, and certainly takes the initiative and the desire to want to do it. I think it's really complex, and I think that because of that, I would never try to do a colorectal surgery, and if I do, somebody needs to call somebody really quickly. But at the same time, I would love to be a partner with you to say, if a patient who lacks means or needs something beyond the colorectal surgery to support their care needs or their well-being needs, we can help you with that.
So again, this team approach. Adrian?
Yeah, so first of all, thank you for being here, and we recognize that you have to take a lot of time out to be here with the work that you're doing. Two things I will say. One is, so I'm an emergency physician by trade, and I practiced through the pandemic. And one of the things that we recognize, and I recognize obviously, and those who are clinicians in the room will recognize, is the care gaps that occur because physicians and providers actually don't have knowledge. I will say that coming out of medical school, I was trained to heal. I had no sense of what the healthcare system was like, and I had to go and educate myself. Now, it does speak to the idea of the workforce and what we actually need in the workforce. One of the things that I did was to implement, you might have you understand you have diabetes educators and other folks who are very disease specific. Well, we implemented a process where we had actually folks come to the emergency department to specifically provide education to patients where we recognize that care gap. And that was sort of kind of like a community health worker, sort of like a navigator, and a number of different spaces. But it is increasingly important to be able to do that because of the savings that occurs. And when I say savings, I'm not talking financial savings, I'm talking about health savings that occurs when you're able to put that resource in place in order to help not just patients navigate, but also to help physicians and providers and experts in their space know what is out there and how to navigate across that space. So I think it's really very important, and it needs to be implemented, it needs to be part of our care design.
Can I have 30 seconds on that one?
Yes.
So don't forget about United Health Group and Optum, the largest ambulatory system in the country, and employ tens of thousands of physicians.
Yeah, the watcher you be giving the mic to.
They're going to recruit, I'm going to recruit too. No, seriously, and hopefully in 20 seconds or less. One of the things that you made me, and it's a great question, and it's one I don't think we have solved, but it makes me think about physician efficiency. And we spend a lot of time on physician decision support tools, analytics into the point of care and into the workflow, and trying to clean up claims and prior auth and all the other stuff that pulls you all away from, one, providing care, but then two, wouldn't it be great if you did have some time to these points to get closer to understanding how the rest of the healthcare system and the ecosystem operates around you. So we are, in our business, spending a lot of time trying to get physicians to a place of, one, being involved in sort of the design of all the tools they're using, get them upstream, but then also try to pull them into sort of understanding how this whole incredible system works. So there's more work to do. Thanks for that.
All right, we got a question here, please.
Hi, I'm Dr. Leanne Burnham from Morehouse School of Medicine, so I'm already claimed by Dr. Tyndall, Dr. Montgomery Rice, so I don't need any cards today. But I am assistant professor and being a translational scientist that's been working on prostate cancer health disparities for a decade, and all of you on the panel, these issues are not new to us, right? So it didn't take 2020 and health disparities during the pandemic to come to the light to sort of turn the light bulb on for us. I'm interested to know, out of curiosity, do you think that in the next few years that this attention and focus is still going to be here? Do you feel that it's being sustained, or do you feel like it's going to perhaps fall by the wayside?
Thank you. So I'm going to start with Jenna because I know that the investment community has really taken social impact funding seriously. And so do you think that this is a fad, or do you see this as the beginning of something that can evolve to be even more?
I don't think it's a fad, and I don't know if that's personally because I'm very passionate about it, but I do think, as you mentioned, these disparities have existed for a while. I think some of the difference is that everyone could see it during the pandemic, and whether they didn't understand it, there was naivety, or ignorance, whatever it was, I think everything was laid bare, and you can't ignore that. You can't go about your daily life reading the news without understanding that. And so I think just that flow of capital, and even the younger generation really saying kind of, okay, I want to invest, and I want to invest to have a purpose. I think one thing that goes along with that is being able to show what that impact is, and getting that data and following it through and having those metrics and reporting it is a little bit of the harder side to really show it. And granted, you may make an investment and you're trying to look over a 3 to 5 year time horizon and it doesn't play out as you had thought. And that does happen, but that's not to say that you can't find other investments. So I don't think it's a fad. I think there is more money about it, but I do think it's very personalized. It's very values-based, what matters to you and how you want to go about it, and where in that ecosystem you want to devote your money. And then again, kind of following that value change and kind of how you can do it. So it can either be in products, so social themed products, or other things you do in your vendors, diverse vendors that you use, or kind of a diverse broker. We have different programs kind of looking at it from that fiduciary aspect, making sure the vendors we have kind of have diversity, working with diversity councils, having sustainability, having better representation, because representation really does matter. And then looking at broker-dealers, having clients being able to invest and make sure you're working with those diverse brokers. Obviously subject to our rigorous due diligence standards, but nonetheless, you're helping kind of those smaller shops that are up and coming kind of have liquidity, develop themselves in the market, and give them an opportunity, again, from that representation standpoint, so making those opportunities or having those social themed investments. For example, one of the ones we have is a money market fund, a government T-bills, but what it is, it has a partnership with the Thurgood Marshall Scholarship Fund, and so BlackRock donates 5% of our management fees, so not coming from client money, but what BlackRock would have got to the scholarship fund, as well as kind of developing an internship program with it. So there are different ways I think you can go about it. I think what we're trying to be is listen to what clients want, because like I said, it is very specific to individual clients, so trying to create some broader-based solutions, kind of what we've done with our own fund, our Impact Municipal Fund, which is really looking at kind of some of those themes I highlighted earlier. The primary ones are healthcare, education, and affordable housing, but also kind of more dedicated or more specific investments, such as our bio fund, which looks at Black and Latinx businesses.
Thank you. Norm, any comment
Yeah,
on
I was gonna-
the
so,
intentionality and how do we make sure that this is not a fad?
Yeah, I love that response, Jenna, and we certainly are feeling that from being someone who works with investors a lot. Boards are leaning in very, very heavily in a very intentional and real way. Regulators are leaning in too. And then I think the thing that feels different for me this time, because I get that question a lot, is eyes have been open around the total cost of care and real social impact. So people are being exposed to metrics and numbers that I don't think they either saw before or just didn't pay enough attention to. And suddenly it's like, these impacts in these underserved communities are real, and they cost society dearly. So I think that we're just in the early innings of this as it relates to kind of a focus on what we're going to need to do to really drive down disparities. And I'm actually beyond hopeful. I think there's enough push and stimulus that we're going to be into this for a long time.
So this is I'm gonna deviate a little bit. So guys, I hope you all knew that I wasn't gonna stick to just these questions. So anyway, and I want to think about this from a perspective of what else is out there that may widen the gaps in healthcare, in health. And one of the things that I think a lot about is climate and environmental influences. So tell me how you at your respective organizations are thinking about climate and environmental influences that may be or have the capacity to widen healthcare gaps, and what can we do about it now that may save us grief 10 years from now? DeVecchio?
Yeah, so Jenna spoke earlier about ESG, and I suspect most in the room know that E in ESG is the environmental. And so this kind of social impact or social awareness about the impact that we have broadly certainly applies in the healthcare context. In the environmental piece, I think we are knowledgeable about on a global context in terms of the environmental impacts on health, in terms of air quality, infrastructure, and the like, but also, quite honestly, from a business perspective, healthcare hospitals actually are some of the bigger contributors to adverse climate impact in a number of different ways, just by the complexity of our operations and the types of chemicals and energy that we use. And so the first thing I would say for us has been about being a responsible member of not just the business community, but the local community, and being conscientious about how we deploy various energy sustaining and climate impact reducing efforts in our operations, in our core operations. Spreading that mindfulness amongst our teammates, so thinking about how we deploy not just sort of automated solutions to reduce energy use, like turning off lights and things like that, but also encouraging people to recycle and set up programs like that. But we also do it as a part of the community. So we're a part of our local chambers, and we're looking at when we're bringing different businesses or attracting and recruiting businesses to our community, how do we think about where those businesses are situated so that there isn't an adverse impact on those more climate adverse industries being associated or placed in socioeconomically disadvantaged communities, furthering that disparities that you're talking about. Or when we're talking about investments in developing communities, that we're not putting them in places proximate to freeways where, again, more adverse energy, or I'm sorry,
So
climate.
when you all are thinking about where you're gonna build another hospital or something, if you're thinking about that, you are thinking about the impact that that will have on the entire
That's right.
community around.
LEED standards for engineering and design that are designed to, again, lower the impact or burden, and also then create the types of jobs and people who could do those jobs that actually allow them to be a positive contributor to that as well.
Thank you. Adrian?
So, it's so interesting that this is happening. We know that at a very elementary level that oftentimes your healthcare outcomes could be determined by your zip code. And we also have begun to understand the fascination around science and epigenetics and how your environment actually impacts disease and outcomes. We're learning more about that every day. We have researchers who focus on this issue all across the planet, but obviously too at Morehouse School of Medicine. So I think deepening our understanding of the impact of environment on health and health outcomes on a biological basis is also important, not just on a social basis. One of the works that's actually being done by our Satra Health Leadership Institute, along with the connection with Google, is the Health Equity Scorer. If you go online, you can actually see that we actually, and I would say we, because really they're the fabulous people and the Health Equity, Satra Health Equity Institute, and also at Google, who've really looked at developing scores that are based obviously not just in comorbidities and so on, but really the environment, where you live, what your zip code is. And so we have to understand, one, that climate, environment, pollutions, tox, all of that impacts health outcomes. There's a biological basis to that we're actually investigating and beginning to understand more of as we begin to really, I think through all of the issues and impact health equity. It's incredibly important. And I think that when we think about social investment and sustainability and helping to ameliorate health equity issues, that has to be part of it. So the point is that when we think about medicine, it's not just about healing the human body. There are so many other factors that are intricately involved in health outcomes we must think of.
Norm, anything the United Health Group, Optum are thinking about in this space of the environment and dealing with climate issues?
I would say that, we formed our Office of Sustainability in an endeavor to answer that very question. So we asked Patricia Lewis, who's a very senior executive in our company, to step into this role. Our sustainability office has sort of the energy sustainability component, diversity, equity, and inclusion, and then health equity as the sort of three legs of that stool. And Adrian just articulated that beautifully. It's really all about how we understand over the long term how the environment, how all of the social elements that we're dealing with, both internal to our organization and the communities we serve, how they all ultimately impact not only health equity, but sort of the long-term viability of our business and the communities that we're serving. So we don't have that answer yet. We don't have a good answer yet. That's the work that we're starting to do now. It's a very, very important pursuit for us, and we're looking forward to the journey.
And I think it's important to acknowledge when we don't have all the answers yet.
Right.
Yeah.
Again, the reason for partnerships and connections, right? Because there may be somebody sitting in the audience who may have an idea about how a healthcare delivery company or insurer may want to think about environmental solutions. Jenna, do you want to comment on that question at
Yeah,
all?
I mean, I think it's just important to bring it to that infrastructure aspect. I mean, there's been several high-profile cases. I mean, the Jackson, Mississippi water crisis and kind of the lack of running water for a predominantly Black population, and the contaminants that leak into the water system. You have what happened in Flint, Michigan a couple of years ago. You have the Camp Fire out in Paradise, California, which had cancer-causing chemicals infiltrate the water system, and kind of the entire, or the bulk of the settlement they're receiving from the electric company is going to build kind of that water infrastructure, but unfortunately it's gone into the groundwater and the lakes and streams. And so kind of how do you rebuild a town if you can't have that clean water? You have schools in Philadelphia that have neglect, and kids are exposed to lead, paint, and asbestos. And so a lot of it is financing this infrastructure in kind of how do you do it so that we aren't impacting the health of the community? And again, there aren't a lot of financial resources from those local communities from a tax base. And when you look at it from an economic perspective in terms of kind of what their taxes are, their income taxes, the sales taxes, their water bill, their electric bill, there's only so much that these populations can absorb. And so how can we make sure that we're not letting these infrastructures go into neglect? And also from the standpoint of rural communities, how do we make sure kind of from a mass transit or public transit perspective that we can connect with them? I mean, we've seen mass transit right now. You didn't have some of that connectivity with ridership down because of hybrid work. Questions on kind of where are we going to invest in mass transit? Schedules are different. I think the interesting thing we saw during COVID and looking at a lot of surveys from transit agencies across the U.S. is that healthcare workers predominantly were the ones to use it during COVID because they had to get to work. Also along the income perspective, kind of what percentage, if you're 50% of the area median income, kind of you don't have a car, so you rely on it. And so if you're cutting back services, you really are limiting some of that economic mobility and that job mobility. So really kind of just being mindful and understanding kind of how can we really fund these operations and maintenance and to make sure kind of we aren't contributing to kind of the healthcare, direct healthcare, or kind of how we make sure we're able to have access to the resources that people need and the communities need.
Thank you. And we're gonna, guys, we have about 14 minutes left, but I know how long y'all talk, so I'm gonna ask one question. That will, and we'll put you all on a timer. But I think this is important because we are here at Health Connect South. And this is about building partnerships and relationships. So I'm going to ask you this question. Who would you like to partner with to work towards eliminating health disparities, to achieve health equity, and why? And Jen, I'm going to start with you.
Quite honestly, I would say, given we are covering the U.S. and I work for BlackRock and we have a tech focus, I would really love more data. I think some of the challenges we've faced and something kind of Delvecchio alluded to before is that data is out there, but who owns it? How do you get credit for it? What we've also found is that it's not necessarily structured properly, or it's not usable. So there are organizations that collect data with never the thought of selling it or using it for another purpose, and so there's hurdles of that. And so how can we go about kind of creating more of this infrastructure and getting this data out there, whether it is for a purpose of being paid for to use in kind of an impact strategy like I have, or for a public purpose of connecting dots. I think just kind of how can we get data out there in structured format, as well as kind of across the spectrum, kind of when we were looking at our social opportunity model, integrity of the data was a big thing. And so there's a vast amount of data out there, but coverage is what we need. And I understand you might be more of a narrow market versus kind of a national market, and that's fine, but just how can I partner or get data to really help move the needle, to find those investments, find those communities, find where we can have some of those greatest disparities, and then find the projects and connect it so that we really are providing capital to those communities. So that would be my request.
Adrian?
So I don't know if this was a trick question, but I'll tell you. It's the community.
Oh, yeah.
Right? So we can, we're gathered here obviously to connect with each other about the ideas that are important and the collaborations that are important amongst us. But without the communities that we serve, who I actually think probably do have some of the answers, if not many of the answers, we would not get anywhere. And I learned this actually from a study that I participated in. It was a PCORI-funded study that focused on transitions in care from the emergency department to home. And it forced us to do something that Pukori forced us to do, which was to take on patients as our partners, patients as part of our boards, patients who would give us advice, patients who we could go home to. And I'm going to switch to people and sit eyeball to eyeball with them and ask the questions about what their needs, and they will tell us why they do what they do. And so in order to get that data, we need to partner with our community so we could build the trust that is necessary to be able to build all upon the collaborations that we have. So it's a short answer, Dr. Montgomery Rice. I didn't take, 5 minutes.
Yes, that is a short answer for you. Devecchio.
Okay, so mine is 3-part, but it'll be quick.
No, we have a little bit.
We got time? Okay, good. You heard her say it. So I too thought maybe this is a trick question, but I appreciate that Jenna went first. So I have 3 parts. My first one is I'm a fan of the adage, why did Jesse James go to the banks or rob the banks? Because that's where the money was. So I want to go to anyone who has resources and means, because I think that's important. But that is not in and of itself sufficient. 2, I want to go to people who have a orientation, and these can be one and the same, obviously. People who have a organization or orientation or predisposition to actually want to be a part of this solution, and so they are actually invested in it in some way already. Can be thought leaders, can be researchers, can be people just passionate about it who are actually wanting to roll up their sleeves and be a part of the effort. And then I absolutely agree with you, Adrian. If members of my team, and there are a few here, would say, I often say, I find a lot of times that the opportunity, meaning the challenge, right, and the solution often coexist in the same space. And so many times we, the learned, come to people like, aha, I have the answer to your problem, and they're going, wrong, right, or nice try, or close, but not exactly. And so that partnership with the community, actually going to people and trying to figure out, like, here's what I am seeing, or here's what I'm thinking, what do you think? Again, validating, but also gives it a higher probability that being a part of the solution means that they'll own it, and they actually will be, invested in making it work. And I say, the money, or the moneyed, the interested, and the people who will benefit from it. That's who I want to partner with.
And Norman.
I can be short because I would have gone to community first, too. I'm fascinated by the last mile element of our ecosystem. No payer, provider system, or anyone else can be effective without the FQHCs and the community organizations and all the social groups that help us sort of deliver all these services. So I think partnering with them absolutely critical. But one pivot we're focused on making at our company is, our focus last 10 years has primarily been on our populations, our member patient populations, which is pretty much where you would start to drive health equity. But I want to see us be a convener. I want to see. We may go head-to-head with other payers and provider systems day to day, but really we should all be working together, payers, providers, academic institutions, CMS, across the stakeholder group to figure out how we solve some of these larger challenges, because we're not going to get it done, any of us, on our own. And I was so excited to get this invitation, because this feels to me like a super important convening. So that would be where I would go.
Thank you. And what I would ask you to do is to turn your attention over here, and I think these are white whales, maybe?
Belugas.
Blue whales?
Belugas.
Belugas.
Beluga.
Belugas.
There you go.
But they're swimming in unison. They have been here, you all the while, and not disturbed by all the activity here, but in their own space, enjoying the environment that's been curated for them. Someone cared enough to curate an environment for them that met the needs that they have in order to be doing just that. Imagine if we went out to our community and asked them what they needed, but also partner with them for the solution. And if the solution didn't exist, we co-created it with them, or because they're the one who needed it, it was created and we let them own it. Imagine the flow of data that would seamlessly come to us to address the next pandemic, the next issue that is coming down the line. It is that perspective that I think engages people and keeps them interested. It is that perspective that I think allows for us to go to investors or other foundations or other philanthropic organizations, or to help HHS and others create the right funding mechanisms to address the challenges that are being experienced by people in communities that have needs. We are the ones who have the responsibility for ensuring that we are spending our tax dollars appropriately, because the NIH, CMS, they're all funded through and by whom? Us. So we ought to provide care and direction to how those dollars are allocated and what they're allocated for. And they should always be allocated for solving problems based on community needs. And if we were to do that, using all of our assets, all of our resources, all of our interests and desire, I know that we will be able to give people what they need, when they need it, and the amount they need to reach their optimal level of health. And guess what we would achieve? Health equity. So thank you so much. Thank you to my panelists. Thank you for indulging in what I hope was a meaningful conversation to bring to light why you were selected. Your organizations you represent have been on the forefront of leading the creation and advancement of health equity. It has not gone unnoticed. It is appreciated. Thank you to the organizers of Health Connect South for understanding the value proposition of having a discussion that's centered around solutions and not cataloging another problem, but talking about solutions. So thank you all, and have a great remainder of the day. Thank you.